Good morning, good afternoon, good evening, everyone. In this talk, I'm going to cover the first trimester markers in fetuses with open spina bifida. And spina bifida results from a midline defect secondary to the failure of the closure of the distal neuropore during the early stage of the embryogenesis. The detection of spina bifida is largely happens in the second trimester. And if you look at the history of the detection rate, from just relying on the history or the risk factors was only about 5%, to using maternal serum alpha fetoprotein, the detection rate was 75%, to using ultrasound in the second trimester, the detection rate is extremely high, is more than 98%. And that's because we don't rely on just the direct, for the screening or the direct visualization of the spinal defect. We rely on looking at the cranial and the cerebral signs. And this cranial and cerebral signs result because you have a defect, you have a leakage of the CSF into the amniotic fluid, and therefore, because of the leakage of the CSF, decreases the pressure in the subarachnoid space that leads to caudal displacement of the brain. Is what we call the Chiari-2 malformation, and that results into the change in the appearance or the shape of the skull when you have a scalloping of the frontal bones, and that corresponds to the lemon-shaped head. And also the obliteration of the cisterna magna, and also the change in appearance of the cerebellum becomes banana-shaped cerebellum. And therefore, relying on this, the cranial and the cerebral signs, we managed to have very high detection rate using second trimester screening. So what about in the first trimester? Well, it is actually challenging, and it's particularly challenging if you're going to rely on direct visualization of the defect in the spine. And often you really need expert opinion doing transvaginal ultrasound scan or using 3D imaging. So where is the data to support what I said, that it's really challenging to detect spina bifida in the first trimester? Well, if you look at the EuroCat data, that's from across Europe, and the data from between 2013 and 2017, only 6% of cases of open spina bifida, and all my talk will be referring to open spina bifida because actually we often don't diagnose closed spina bifida prenatally. And in fact, most cases of spina bifida tend to be open. So only 6% were actually diagnosed in the first trimester. And therefore, again, when it comes to the first trimester, we would rely on the indirect signs, cranial and cerebral signs, rather than visualization, direct visualization, which obviously you needed for confirming the diagnosis. So have we improved over the years? Well, this is data from the United Kingdom where I work. This is a multi-center large screening study where actually spina bifida is one of the lesions or the abnormalities that are sometimes detected in the first trimester. The detection rate in this study was about 15%. But things have improved over the years. So this data was data before 2009. And actually the same research group published more recent data where they looked at the detection rate. That's data between 2009 and 2018. And you see that actually in the first trimester, the detection rate of open spina bifida was actually improved to 60%. And that's because looking at the indirect signs in the first trimester that I'm going to take you through. So what happens? It's exactly the same pathology. Is the fact that you have the leakage of the CSF, and therefore that leads to obliteration, the caudal displacement of the brain, and the posterior shift of the brain inside the skull. So here, this is a diagram. This is a mid-sagittal view. It's the one that we often use to measure the nuchal translucency. So it's routine view in the first trimester. And you see here, this is the thalamus, this is the brain stem, and the black here, the space here corresponds to the fourth ventricle, which is called the IT, or the internuchal translucency, which is obviously first described by Professor Abichawi. And the white here is the choroid plexus of the fourth ventricle, and posterior to that corresponds to the cisterna magna, and here the occipital bone. This is what will be a normal fetus. In cases of spina bifida, when you have this caudal displacement of the brain secondary to the CSF leakage, you will have actually change in appearance because you will have the midbrain shifted, the brain stem, and it's thickened, and you have the key thing is really the obliteration of the fourth ventricle and the cisterna magna, and therefore you don't see normal IT. Here, this is a mid-sagittal view of the fetus in the first trimester. Again, the thalamus, you see the brain stem, you see the fourth ventricle here, you see the choroid plexus of the fourth ventricle, you see the cisterna magna, occipital bone, and this is where you measure the nuchal translucency. And as I mentioned, first described back by Professor Abichawi as the intranuchal translucency, or the IT. Over the years, people have sort of described similar or sort of different features in the same, exactly the mid-sagittal view. So one feature, one sign that I'm going to talk to you about and show you the diagnostic or the predictive accuracy of the performance is maybe the 3 echogenic lines, or actually sometimes even people describe it as 4 lines. And the 4 lines correspond to the anterior border of the brain stem. Here the brain stem, the posterior border of the brain stem, the choroid plexus of the fourth ventricle, the occipital bone. And you see when you have a fetus with a spina bifida, you have disturbance. You don't really see this 4 echogenic lines. So the same pathology or the same mechanism would lead to some changes that you can see either in the sagittal plane or you can see the axial plane. And I'm going to show them to you. So again, just to go back to the pathology, it's an open spina bifida. You have the leakage of the CSF, caudal displacement of the brain, compression of or obliteration of the fourth ventricle and cisterna magna, and therefore this IT or the intranuchal translucency will be a lot smaller or actually not even visible. And then the brain stem will become thicker, and actually the distance between the brain stem and occipital bone will be smaller because of the caudal displacement and the obliteration of the fourth ventricle. And therefore, if you look at the ratio between the brain stem and the brain stem to occipital bone, will be increased of the more than 1. And you can see that beautifully demonstrated in these images and that diagram. So here again, that's a normal fetus. You see the thalamus, you see here the brain stem, the posterior border of the brain stem. This is the fourth ventricle, or it corresponds to the IT, or the intranuchal translucency. This is the choroid plexus of the fourth ventricle. This is the cisterna magna, and this is the occipital bone. This is a normal fetus, and this is the fetus with open spina bifida. And you see, you don't see this normal anatomy. And in fact, the IT or corresponds to the fourth ventricle, for example, and as well as the cisterna magna, a lot smaller or obliterated. And you see here on the right-hand side, where I showed you that actually the brain stem, which is a normal fetus here, it becomes thickened in a fetus with open spina bifida, and the distance between the brain stem and the occipital bone is shorter or smaller, as you can see here in a fetus with open spina bifida. Again, sort of, you can see demonstration of the same view with some illustration or sort of diagrams demonstrating, again, the disturbance of the IT, the fact that caudal displacement of the brain, the fact that the thickened brain stem. So where is the data to support what I said? Well, here in the data in fetuses on the first trimester, on the x-axis, it's the crown rump length. On the y-axis, the diameter of the brain stem here, and you can see that the red dots are fetuses with spina bifida, and you can see the brain stem diameter is increased, as you can see here in fetus with open spina bifida, and the distance from the posterior border of the brain stem to the occipital bone is reduced, as you can see here on the right side. All of these red dots are fetuses with spina bifida, while the reference range here was normal fetuses in the first trimester. And therefore, if you have the brainstem thicker and the brainstem to the occipital bone distance is shorter, if you look at the ratio will be increased. In fact, the ratio in fetuses with open spina bifida, if you want just to use a cutoff, is more than 1. So see here, this is in normal fetuses, usually this ratio between the brainstem and the brainstem to the occipital bone is usually between 0.5 and 1, while in fetuses with open spina bifida, the ratio is increased, it's above 1. And in fact, actually, in cases of fetuses with Dandy Walker malformation, is the opposite. So the ratio is often less than 0.5. This is a case of a fetus with spina bifida, brainstem is thickened. The distance between the posterior border of the brainstem and the occipital bone is shorter, while actually in fetus with Dandy Walker malformation is the opposite pattern. The brainstem is smaller and the distance between the brainstem and occipital bone is increased. So the ratio is less than 0.5. The other thing also, when you have this caudal displacement of the brain inside the skull, that also leads to change in appearance or in this angle, the frontomaxillary facial angle. How do you measure it? It's a distance or the angle between a line that corresponds to the upper border of the palate or the maxilla, and a line that's between the anterior border of the maxilla or the palate and the frontal bone. And this angle approximately in the first trimester is about 90 degrees, while in fetuses with spina bifida, because of this downward displacement or shift of the brain, this angle is actually smaller in fetus with spina bifida. And again, this is the data to support that. This is the frontomaxillary facial angle, and this is across the x-axis is the crown rump length, and you see the red dots is fetuses with spina bifida, and this angle tends to be smaller in fetuses with open spina bifida. So I mentioned to you that there will be signs that you see it in the axial plane, and exactly secondary to the same pathology, there will be some signs that you see it in the axial plane, so the sagittal plane or the axial plane. In fact, both planes are actually routine planes in the first trimester. So again, so the open spina bifida, the caudal displacement of the brain, the posterior shift of the cerebral peduncle and the aqueduct of Sylvius. This is in a normal fetus. This is a fetus with spina bifida. You have this posterior shift of the brain, and therefore the distance between the aqueduct of Sylvius here on the occipital bone is a lot shorter compared in fetuses with open spina bifida compared to normal fetuses. And in fact, that would I'll show you later in a later slide that corresponds to a crash sign. So again, that would result into, obviously, I showed you the abnormal frontomaxillary facial angle, but also that actually the small biparietal diameter. And in fact, even in the second trimester, there's plenty of data that show that actually fetuses with spina bifida tend to have a smaller head, so the smaller biparietal diameter. You also see that in the first trimester, and that's because of the fact that you have a smaller lateral ventricle and posterior and fourth ventricle, so they have a small biparietal diameter. So here in a transvaginal ultrasound, you see more the detail of the fetal brain. Here, the cerebellum. You see this is the fourth ventricle. This is the choroid plexus of the fourth ventricle. This is the cisterna magna. This is a normal fetus. And when you have a fetus with spina bifida, you have the posterior shift of the brain. And therefore, here, your obliteration of the fourth ventricle and the cisterna magna. And then you even in the first trimester, you could see here almost the banana shape cerebellum. And that's on the axial views, again, in this diagram. But the other thing as well, another sign that you can see here is this dry brain. So the fact that normally you'll have the choroid plexus surrounded by some CSF in the lateral ventricle, while actually if you have a fetus with open spina bifida, you'll have this leakage of the CSF, and almost you see the choroid plexus filling the lateral ventricle. There is very little fluid around the choroid plexus, which is the other sign that's been described as this dry brain. And as I mentioned to you, the posterior shift of the brain, the cerebral peduncles, and the aqueduct of Sylvius, and you can see that beautifully in this diagram, and that corresponds to the crash sign that I'm going to show you later. Okay, for a screening program, you really need to have a simple sign, something that everyone can do it with not too much intensive training, or something that's not just limited to the experts in the tertiary centers. So I mentioned to you earlier that the fetus with spina bifida, they tend to have a small head or small biparietal diameter. And in this paper, we published it more than 10 years ago, where we looked at fetuses with spina bifida, and you can see in the second trimester, they have a small biparietal diameter. But also when we looked at the measurements in the first trimester, also we found that a large proportion of them, they tend to have a small biparietal diameter. And you can see here, this is fetuses with open spina bifida. This is the control or the normal fetuses, and they have a smaller biparietal diameter. What we found is that more than 90% of these fetuses, the biparietal diameter was less than 50th centile, and nearly half of them, the biparietal diameter was less than 5th centile. And therefore, if you just use just the biparietal diameter, which is something that we all measure in the first trimester, you can actually detect more than half of cases of fetus with open spina bifida. That was published, as in, more than 10 years ago, and in fact, at the same time, also the team led by Rabi Chawi also published very similar data, where you can see here the biparietal diameter less than 5th centile. You see it in 60-70% of fetuses with spina bifida in the second trimester. But if you just shift the measurements to the first trimester, we found about a quarter or nearly a third of them actually the biparietal diameter was less than 5th centile. And again, around the same time, the team led by Yves Ville in France published very similar data, where they found that actually biparietal diameter, using just biparietal diameter in the first trimester, 11 to 14 weeks, you can actually detect half of the cases of open spina bifida. And because you only, obviously, the screening, you identify the high risk, and then you refer to the expert opinion. So you're only going to refer about 5% of the pregnancies for the expert scanning using transvaginal 3Ds, and to interrogate the fetal spine and the brain and the cranium using this, or looking for additional markers. Again, around the same time, the team led by Professor Nicolaides also publishes data combining the biparietal diameter with the maternal serum alpha fetoprotein. I mentioned in the beginning of my talk that in the second trimester screening years ago, we used to use the maternal serum alpha fetoprotein, but in the first trimester, combining the biparietal diameter and the maternal serum alpha fetoprotein could detect 50% of cases of spina bifida for about 10% false positive rate. And because actually the consequences of the false positive rate is not going to do a necessarily invasive testing with risk of miscarriage, you can just refer this patient to expert opinion or fetal medicine specialist to really have detailed look at the fetal spine. In this case, you can afford to have a higher false positive rate. We also try to look at additional markers or quantify and improve the detection rate. So we published for years before that about the biparietal diameter, only 50%, so it's not really a great screening marker on its own to be implemented for the first trimester. So we actually looked at this. Remember I said there's a dry brain, the fact that almost the choroid plexus fills the lateral ventricle. So we try to quantify that, and we measured the choroid plexus length ratio to the occipitofrontal diameter. And in normal fetuses without spina bifida, it's about half. So the mean choroid plexus length is the occipitofrontal diameter. This ratio is about 0.5. It's about half. While actually in fetuses with spina bifida, it tends to be more because it's less CSF, and therefore it was average with 0.6. And when you do the predictive accuracy, the accuracy was extremely high, 0.9. So very good for screening markers. And what does it mean in practice? Means that if this ratio is increased, the positive predictive value, more than 90%, means if you have it high, more than 90%, this fetus have an open spina bifida. And the negative predictive value means if it's not there, more than 99%, the baby does not have a spina bifida. And we also developed, we published it in an American journal, and we developed a calculator to actually give you an individualized risk assessment. So based on the measurement for each patient, you can develop or derive individualized risk assessment for a fetus with open spina bifida. And again, the same sign was also seen, or these findings or results replicated by the team in Italy led by Nicola Volpi. So I mentioned about the crash sign, which is the axial view, which is exactly the same. It corresponds to the posterior shift, caudal displacement of the brain, posterior shift of the cerebropeduncle and the aqueduct sylvius. And this is was described as the crash sign. This is the normal fetus, and this is in fetus with spina bifida. So how do we make sense? I mean, there are so many signs, ultrasound markers have been described in the first trimester in fetus with open spina bifida. And this very nice paper tried to actually look at these markers and report on the predictive accuracy. So this meta-analysis of the all reported cranial ultrasound markers of the first trimester. And what they did, I showed you earlier, I grouped them into signs or markers that you see in the sagittal view and markers that you see in the axial view. In this meta-analysis, they looked at them whether qualitative or quantitative. And in this table, they summarized, you can see the list of all the qualitative signs. I've already described them to you. Remember the 4-line view that I described to you earlier, the IT, the obliteration of the cisterna magna, also the aqueduct of Sylvius to the occipital bone that's seen in axial view. The rest are all in the mid-sagittal view. The maxilla occipital line. So basically, if you draw a line between the maxillary, the upper border of the maxilla or the palate, and then to draw it to the occipital bone in fetuses with spina bifida, because of the caudal displacement of the brain, you will have the junction between the midbrain and brainstem is below this line, while in normal fetuses, it should be above this line. And the quantitative, which is, again, I went through it, so some of these ultrasound markers, but actually quantification. So if they are, should be small, for example, below the 5th centile, below the 1st centile, and they increase above the 95th centile. So actually quantification of these ultrasound markers. And they're a long list, and I'm not going to go through them because of the time. But what is the predictive accuracy? And again, I'm not going to take you through the statistics, but actually this meta-analysis, you see, this is a qualitative. So they looked at all the markers, qualitative assessment. And on the right side, this is a quantitative assessment. And this is something called the force plot. So each of this line is a study, and you pool or you combine the data from the studies. And if you see the pool sensitivity, and if you compare, should we just use the qualitative or should we use a quantitative assessment? You see that qualitative had a lower sensitivity, it's about 76% compared to 84%, had higher specificity, so nearly 100%, 99.6% compared to 96.3%, and the diagnostic ratios much higher, actually, using the qualitative assessment compared to quantitative assessment. What does it mean in practice? It means in practice, actually, for a first line, for just a screening, I think it's probably better to use a qualitative assessment. Just if the sonographer or the fellow, they actually pick up that we can't see the 4 lines, you can't see the IT, or the IT is small, or there is obliteration, and then that would be referred to the fetal medicine specialist. And in the same meta-analysis, where they just included the studies that did compare the two approaches, the qualitative versus quantitative, in the same cohort of fetuses, the same population, you see exactly similar pattern to what I showed you. The qualitative assessment have lower sensitivity, but higher specificity, and overall have higher diagnostic odds ratio. Okay, finally, what about artificial intelligence? Can actually help us improve, and this is very recent data. This is just published as an abstract, and the work is by Yves Bale and Rapi Chawi. And here reporting that using artificial intelligence can improve the sensitivity to 88.5% and the specificity to 88.5%, sensitivity to 100%. So certainly using artificial intelligence or AI can help us improve our ability to detect spina bifida in the first trimester. So my take-home message is, it is true that actually effective screening diagnosis of open spina bifida in the first trimester remains challenging. I showed you this data. This data, some of the earlier studies looking at the biparietal diameter was published, 2009 with the IT, for example, so more than 10 years ago. And still we don't have a formal first trimester screening for open spina bifida. And therefore need to overcome these difficulties by maybe having a simplifying approach or actually using maybe artificial intelligence. And it's likely that actually combining both the axial and the sagittal views, and these are two planes that are routinely obtained in the first trimester, it's likely to improve our first trimester screening using protocol, dedicated training. But certainly if you do as a first line screening, probably it's better to use a qualitative science, while actually the quantitative science will be reserved as a second line by fetal medicine expert in tertiary centers. So I'm gonna stop here. Thank you very much for your attention and happy to take any questions.